to the third and final session of this webinar. And we'll begin with Dr. Panayotis, who will give us an update on COVID-19 in Greece.
Okay, thanks for the invitation. Can you hear me, please?
Yes.
Yes, we can.
Okay, so I will continue in that case. Okay, I have to discuss about the current situation of COVID-19 in Greece, what is done in terms of prevention and therapy. And let's start now, see if it rolls. Well, the first cases of COVID-19 in Greece were in 26th February, actually with citizens that were on a trip to Milan or to Egypt, Israel. The peak was on the 21st of April with 56 new diagnosed cases. Current at the 29th of May of this year, we have 2,906 cases, 175 deaths in a population of 10.7 million, roughly the size of Sweden. Just a moment. Now, immediately a national committee for COVID-19 was created for the analysis of the epidemic and proposed the appropriate guidelines measures to all the authorities. And what's crucial, all suggestions by this committee were accepted and implemented by the government. This was done immediately. And there was every day information about how the epidemic is going on in terms of number and instructions. Of course, after the first COVID-19 epidemics, all festivals and activities were immediately cancelled. By January 2020, 13 hospitals in Greece were selected as reference COVID-19 medical units and were equipped with negative pressure chambers. And these reference hospitals were located in different geographical areas in Greece. ICUs, new personnel was hired, doctors, nurses, and new equipment was installed. So they would be ready. For the prevention, as we continue now, all travelers from countries with COVID-19 cases stay in quarantine for 14 days with protective contacts, hand wash, face mask. In case of fever, cough, other symptoms, nasopharyngeal PCR test for COVID-19 was done. The residents in Greece with flu-like symptoms in good clinical condition were advised by a COVID-19 national helpline to stay home with no family contacts and call their family doctor for further instructions. Patients with high fevers, general symptoms, dyspnea were transferred by special ambulances ambulances for COVID-19 suspected cases to a COVID-19 referral hospital in special wards or in ICU as indicated. Patients negative for COVID-19 PCR test was repeated 7 to 10 days later. Well, now the social measures. 10 of March, all nursery schools, universities were closed. 13 March, all restaurants, coffee shops, shopping malls, museums, all type of sports, theaters, cinemas were closed. And 16 of March, shutdown of all the remnant shops with no religious ceremonies were allowed in Greece. And of course, what's left open? Bakeries, supermarkets, pharmacies, all health services, they were open. 18 of March, 10 billion euros government support employment and businesses. 23 of March, total shutdown of all type of transportation of citizens. Every citizen must send at that time an SMS, a national SMS with no charge, to indicate the reason of car drive or walk. There were just 6 pre-specified reasons: going to work, visit to a doctor, personal exercise, pet walk, shopping or of essential goods, or help to a person in need. You have to be stressed that it was only 45 minutes the time allowed for this type of getting out of the house. Sorry. Now, what about the end of restrictions? At 4 of May, free travel was allowed, but not for air flights. All businesses free to operate, schools open, but not the primary schools. There were special protocols for tourist entries. and there were protocol units for random checkups in visitors in mainland and in islands. And of course, special agreements with each country for an agreed master plan in cases of COVID-19 infection in their citizens or for the tourists. Now, there were some clinical studies. I'm talking about only the ones that are, official clinical studies running in Greece. And I started with a few studies that run only in Greece. This study is about to see the long-term physical ability and quality of life in patients with COVID-19 infection. I'll go quickly to the studies. Another one is the impact of quarantine in the effectiveness of telerehabilitation in patients with chronic pain. Another one in Greece running only in Greece, anti-inflammatory clarithromycin to improve SARS-CoV-19 infection early. We'll continue. Super guided and accurate treatment for validation of the risk and early management of severe respiratory failure for COVID-19. And it's still running only in Greece in 14 sites, as you can see. And you can see all the NCT numbers here. They're officially listed. Another similar study is a global one, a multi-center adaptive randomized blinded control trial of the safety and efficacy of investigational therapeutics for the treatment of COVID-19. And it's either placebo or remdesivir. As you can see, there's a global study. Another study running only in Greece. You can see the title. And the drugs that are used is Anakira or tocilizumab, according to the results of a special test that they are running. Some of them have some results. And of course, the famous chloroquine phosphate against infection by the novel COVID-19 is running also in Greece, as well as in many, many other countries. And the President of the United States of America is running his own trial, I suppose. Another study in Greece, remdesivir. You see all the density numbers. You can see it very quickly. I'm speaking quickly because we have, very few time left for the meeting. This is a global study about the functional. Another one that the European Euro-LCL. And I want to stress this particular item. We're talking about prevention with chloroquine. This is an SOS, and I'll explain you why. We have two variants of the G6PD, the A- and the G6PD Mediterranean, which are the most common mutations in human. G6PD A- has an occurrence of 10% of Africans and African Americans, while G6PD Mediterranean is prevalent, as the word says, in the Middle East. The G6PD gene, as you know, you are hematologists, most of you, of course, is located in chromosome XQ28. And what's the big news? The Mediterranean type of G6PD deficiency, in contrast to the G6PD A-, results in very low levels of G6PD in the cells. That means that in the presence in the human body, in the circulation of antioxidants, and one of these oxidants is chloroquine, that results to severe intravascular hemolysis, especially in male carriers, because you have just one copy of the G6PD gene. As I've shown you before, this is a chromosome X. Golden rule: never in people of Mediterranean origin give chloroquine like nothing. Check first for G6PD levels. It's just a vial with blood in any patient that will receive treatment with chloroquine. So just be aware of that, and some of the hemolysis that you might see in several reports in the COVID-19 pandemic may be in patients that received various drugs and they had GXP deficiency if they were with Mediterranean origin, these patients. So it's very simple, but it's very crucial. So let's move next. The Hellenic Society of Hematology had some guidelines, and the guidelines were that every treating doctor, or in some cases medical nurses, should communicate to each of the hematological patients on the preventive measures of COVID-19. All drugs prescription are done and sent to patients electronically, so there's no physical contact of delivering the prescriptions. All patients with fever examined in special units outside the day clinic. I strongly suggested the routine use of growth factors to reduce cytopenias. Follow-up clinics in day clinics of patients should be postponed. Therapy for patients with non-aggressive disease should be postponed. And any suspicious case for COVID-19 infection is referred to the hospital committee for COVID-19. Each hospital had a special committee for its patients. And the general guidelines has been discussed before, that for patients with aggressive disease, e.g. EML fit for chemotherapy, ALL, DLBCL patients, and allogenic BMT patients, the therapy should proceed as planned. For allogenic BMT, we had some problems that the donors declined to give the graft. For patients programmed for autologous BMT, the treating MD evaluates if it can be postponed until the epidemic was controlled. And decision on type of treatment of patients in the day clinic should evaluate the use of an approved therapeutic protocol with minimal patient visits and per therapy if possible. Oops. Sorry, can go. It doesn't change. Sorry for the delay. Sorry, I need some help because it doesn't move the slides. So in my presentation, seems that it's stopping here by the system. There are some more. Okay. If this cannot be continued, so I have to finish here with the guidelines from the Hellenic Society of Hematology. Oops. And this is more or less the measures. The next slides were showing that we have very few, if any, positive cases with COVID-19, rolling between 0 to 5 per day. And all types of communication and travel are now approved, and travel to the islands, etc., etc. But sorry for this dysfunction, but I had 5 more slides, and it seems that they cannot be projected on the system. Well, I have to stop here because I tried several times. It doesn't seem to have any more slides for my presentation.
Professor Paniotis, the technicians will be able to move on behalf of you. Just a couple of more seconds, please.
Oh, it's okay. But I didn't want to spend too much time because we're 1 hour late, as it was very nicely said.
Shall we move on? If so, next up is Dr. Rossi from us, who will talk about cytokine storms and immunotherapy in COVID-19 infection. Dr. Rossi, are you there? I see your icon. Jean-Francois. There you are.
Yeah.
Bonjour.
Is it for me now?
Yes, it is.
Mm-hmm. Okay. The first slide. Okay. Go on, yes. As you know, the first one is, okay. We know that COVID outbreak is fluctuating around the world, and now in Europe it's easier because there is a decrease, and the number of new patients have decreased, particularly in France today, and life is coming back, but we have to improve our knowledge due to the possible recurrence, and we have data to analyze. Next one. Yeah, there are some, as you know, there are some people and populations of patients who have more higher mortality, and cancer is one of them. There was published recently the mortality at 30 days of cause of cancer having COVID, and as mentioned, the comorbidities is one main factor to enhance the mortality, and also cancer when it's not controlled, but also under therapy, it's also an increase of the frequency of the mortality in this type of patients. This registry, as you know, includes more than 900 patients, particularly in the States, and we have to deal with that, and particularly for hematological malignancies, which are more lethal. Next one. So there are many huge number of clinical trials in COVID-19, and I want to focus today on immunodynamics in COVID-19, because this is not well expressed in the different publications, the dynamics and the magnitude of some symptoms, and particularly biological aspects. This is, for my talk, probably focused on cytokine storm, the immune response, but we forgot also the immune exhaustion, and probably the next future, a great number of patients could have this immune exhaustion, and we need immune therapies for that. Next one. Let's go back very rapidly on the immune response and inflammatory response. As you know, in infection, there is a local part with different cellular aspects, with innate cells, chemokines, cytokines, mainly macrophages, neutrophils, and NK cells, and also CD8 cells. There is a regional part for amplifying the adaptive immunity and the humoral response, and a systemic part which is amplifying the inflammatory proteins and amplify the response to organ. There is a balance in this system: inflammation, immune system, but also immune suppression with some cytokines which are secreted, like IL-10, which is in a normal range, a local repair of after an infection. The dynamic and the balance are two main factors which has to be studied, and this is the basis for the precision immune medicine. Next one. Yeah, let's go on this slide in order to say that in green, there is a normal range of an inflammatory followed by an immune adaptive response with antibody response. In red, you have the bad inflammation with a cytokine storm. In sepsis, it's well known, and in some infections, it's higher than in COVID-19. For example, in H1N1 on the other COVID sepsis infection, excuse me. It's also the same in inflammatory cancer also. And there is also an excess it could be have an excess of immune suppression with secondary infection. And all of these bad inflammation, chronic smoldering inflammation following the first period of time or excess of immune suppression could be associated to an immune exhaustion. This is the basis of our thinking, dynamic, balance. Next one. We have to discuss today the immune aspects on COVID-2 infection. I just want to focus on cytokine storm, immune response very rapidly, some aspects of immune exhaustion, and we have also other questions like immune susceptibility to this infection or the immune susceptibility to the severity of the disease. And there are some aspects and actually typing which are now studied in this type of thing. Next one. Yeah, go back to the biological data, separating and comparing the severe to the moderate patients having COVID-19 infection. You know that the neutrophils are higher in the severe form, lymphocytes are lower count in severe form, D-dimers for endothelial activations, LDH for pyroptosis for neutrophils, procalcitonin, which is linked probably with a bacterial infection, secondary bacterial infection, ferritin, the macrophage activations, and albumin, which is decreased in severe patients, and CRP increased, are linked to the IL-6. On the lymphocyte, there is also a more in severe patients, there is a lower reduction of CD8 and CD4, and a higher reduction of NK cells, which is also linked for the CD8 cells with an amplification of DR and exhausted cells, and also an amplification of a subpopulation which is controlling the autologous CTL cells. Next one. Yeah, we know that there are three parts of this disease, and I don't want to go back on this aspect, but just mentioning that only few patients are very active with acute respiratory distress syndrome and also with macrophage activation syndrome, which is maybe one part of the more severe part of this disease, with a cytokine storm. But for IL-6, for example, in CAR T cells, the cytokine release is higher than that observed in COVID-19. Also in all the other COVID infections, MERS and SARS precedent infection, and particularly in H1N1 infection. The second thing which is interesting to mention is that this period of time is sometimes delayed 5 to 7 days. In H1N1 infection, it's very short, in 2 days with a cytokine storm. This is one thing we have to deal also with this disease. And the second aspect is, as well as in sepsis, IL-10 is correlated to a severe disease, and it's maybe one thing associated to immune suppression and immune exhaustion, and we have to get some data concerning all these cytokine aspects collected in patients and comparing those who are well and repair from the others. Next one. So go back to the alveolar, pulmonary alveolar, which is a local part. You have a normal immune homeostasis, which is similar than that observed in other pulmonary infection. And we have also, which is activation through inflammasome to macrophages, secretion of cytokine, activation of neutrophils, CD8. But there is also an acute lung injury, which may be more active in this disease than the others, due also to neutrophils, activations of endothelial cells, and activation of fibroblasts with tissue injury, leading to floating alveolar liquid in the alveolar, and maybe also to the clinical aspects. Next one. Now we have to ask how to treat this cytokine storm. Corticosteroids, not very easy to have a consensus. It was mainly used in SARS-CoV and MERS, or influenza pneumonia. Anti-inflammatory molecules, anti-cytokines, IL-6, TNF, and IL-1RA, which are the most target cytokines, JAK inhibitors, and chloroquine and hydroxychloroquine by the immune suppression, modest immune suppression aspect may prevent, if it was used at the beginning, this kind of thing. But there is no data for now in this situation, and we have the debate of these drugs actually ongoing. Next one. Corticosteroids are used in septic shock, and if they are used, it's in a small dosage, short-term applications, and probably for patients in whom adequate fluids and vasopressor therapy do not restore hemodynamic stability. It was mainly used in SARS and MERS, or influenza pneumonia, but with a clear demonstration that in influenza, it increased the mortality, it increased the rate of secondary bacterial and fungal infection, and a longer stay in an NCU. In SARS-CoV, it was used in China empirically. 19% of the patients have corticosteroids in Wuhan and other cities for 3 to 15 days, median 5 days, with no real proof of efficacy and a possible benefit, but outweighed by adverse events. And the WHO does not recommend glucocorticoids since February 22. Next one. Anti-TNF, there is some support because the viral spike protein is able to induce a TNF alpha converting enzyme, dependent shedding of the ACU ectodomain. There is one clinical trial in China. I don't find any other in the States for now. IL-1RA by using an Ankira. 4 studies are mentioned in the States or other countries, in Sweden. Next one. And we have the experience of the IL-6 because we use anti-IL-6 in the context of cancer. As you know, there are 2 receptors. One is on a membrane form and a soluble form, and restricted expression on hematopoietic cells and liver, and the other is expressed on the whole organ. And there is a cis and a trans activation with the soluble IL-6 receptor alpha, which is an agonist, and the GP130, the second receptor, which is an antagonist. There are fluctuation of the soluble IL-6 receptor, and we mathematically modelize the usage of these different antibodies against IL-6 receptor or IL-6. Next one. By knowing the different constant affinity, by knowing also the different concentrations of the monoclonal antibody, the half-life, CRP life, etc., the modelization we get now is submitted for publication, but is also submitted to patents because we observe some different aspects, and I can show you just a few thinking about that. Next one. You know that there are many clinical trials targeting IL-6 and IL-6 receptor. 2 studies with cetuximab, which was an anti-IL-6 developed by Centocor and now held by ESA Pharma. Anti-IL-6 receptor monoclonal antibodies tocilizumab, developed by Chugai and now held by Roche, 25 studies, particularly in Italy. And sarilumab, which was developed by Regeneron and now held by Sanofi, 8 studies of these different monoclonal antibodies in cohorts or in randomized studies. Next one. Let's go on some results. For example, the Brescia single center cohort study, which is interesting because one half of the patients are not in the general ward and no ICU beds were available, and the other patients were treated in ICU. There is a response, but only on 60 to 74% based on the respiratory improvement. We have a lack of data on biological aspects. In this cohort, there is something, next one, which is interesting. It's if you are separating the patients who improved or stable, and improvement or stable, it's not the same, but they pulled all of them. There are 2 things. First, the CRP is not completely abrogated, but the CRP is higher but decrease in patients who are in worsen or disease, 23 patients. The second thing is that the IL-6, which is bound and free IL-6, we don't know about that because there is a monoclonal antibody circulating in the blood. It's increasing, and the increase is higher in patients who are in worsened situation or disease than in the group of patients who are improved or stable. This is one thing which could be interesting to see in the next protocol, and we are discussing also with ESA Pharma now, in order to have the free and the bound IL-6 and also the follow-up in the time, in a dynamic way of the CRP. Let's show the next slide, please. This is to be discussed. To get a biological effect, we think that the CRP has to be totally abrogated in a very short time. Why totally abrogated? There is a local production, both in mice model, but also in bronchoalveolar lavage in pulmonary infection. In bronchoalveolar lavage, the concentration of IL-6 is between 4 to 10, maybe some patients to 100-fold higher than in the circulation. If you have not a CRP totally abrogated, you have circulating IL-6 and IL-6 locally available to continue to have some problems in the lung. The second information is based on 2 things. First, there is a slope and a very rapid augmentation of the CRP in some patients who are going to the ICU. We have the example of one colleague who were infected by COVID-19, and the CRP grows from 4 milligrams per liter to 145 in 15 hours. The slope, the rapidity of the increase of the CRP is probably interesting to follow in order to choose the patients to be treated by anti-IL-6. And the third situation, we plot on this curve, which is a curve of the CRP reduction, considering the half-life of the CRP, which is 19 hours. We plot on this curve the patients and the dynamic CRP of patients treated in China and published by by the group in China. If you are looking carefully, all the patients who died and were in worsened situation, the CRP was half than the normal CRP reduction to get a total abrogations. And the problem is the patient with stabilized disease or improvement are the patient who improve is on the curve, but it's not sufficient to prove that this dynamic way could be interesting. We need more data in order to confirm that, and it's also interesting to have this dynamic CRP as well as probably the dynamic of IL-6 under these therapies. Next one. This is another example from Italy. The patient under siltuximab, there is patients who are not abrogated in the 2 to 5 days with higher level of IL-6. The magnitude and the duration of the abrogation, the dynamic, in other words, are very important. We don't know about the clinical condition of these patients, but it has to be seen, and we are discussing with different labs and industrial companies for that. Now, next one. Yeah, the questions at the end are, if we want to block efficiently IL-6, we have some questions. When? Is it during the cytokine storm? And maybe not all the cytokine storm have to be blocked, but some of them, rapidity, etc. We need to ask also the question if during the chronic smoldering inflammation, we have to block also the IL-6, which could be easier with considering the pharmacodynamics of the different anti-IL-6. The duration of the treatment, short probably, because of the immune aspects after anti-IL-6, and to be associated with other therapies, probably with a specific immune response enhancement, antiviral therapy, or following the immune exhaustion and probably having some drugs for targeting that. Next one. So go to the immune response rapidly, seroconversion with the appearance of specific antibody in the peripheral blood, seroprotection, which is another aspect, the use of convalescent plasma, which is an intermediate time waiting for monoclonal antibodies, probably against spike protein, and how to boost also the immune response could be another question. Next one. Just rapidly on the proteins which are expressed on this virus, and the spike protein and also the nucleocapsid protein are both the main targets for an immune response, and this is obtained by analyzing the plasma of convalescent person. Next one. The seroconversion is appearing after 3 to 4 days after the infection, with a high increase of IgG, IgA, and IgM, which is preceding but shortly before the IgG and IgA. Next one. This is another study from China showing that IgM precedes, but IgG is higher between the 12 deaths between 10 to 15 days after the infection. Next one. And there is a kind of heterogeneity for IgA and IgM directed against a spike glycoprotein published by an Italian group, showing that IgA and IgG, which is not shown on this slide, are at the highest level than IgM and probably prolonged time to be present in the peripheral blood. Next one. This is just a magnitude between IgA and IgM in the same publication. Next one. And for biological aspects in terms of serological analysis, there are some data concerning the sensitivity, specificity, positive predictive value, negative predictive value, and consistency rate. I just mentioned one study. In confirmed patient, the IgG better in terms of with a very high level of predictive positive and negative for both in both situations, confirmed patient and suspected patient. In France, the recommendation came from the High Authority of Health with some key points published the April 20, and they are acting later than the other countries serological aspects for the patients, which is now ongoing, and they recommend to make some serological situation after the disease, after the onset of the disease and after the disease. And they publish also a list of the different devices and are authorized for the laboratories, both in public and private situation. Next one. Just few slides on the immunotherapy, which is not on clinical randomized study, but in cohort of patients. Ig used at high dose. The conclusion of this study is we have to use immune therapy with Ig, it has to be at higher dose, rapidly at the beginning of the disease, and probably in a prolonged situation. There are some slides showing the disappearance of the infiltrate on the CT scan, but it's not a randomized study. Next one. Usage of convalescent plasma. It was published for the first time from 5 patients treated in China with a nice reduction of some symptoms, particularly from pulmonary symptoms. And the follow-up of the antibodies was made in the different patients. Next one. It is tested in the eastern part of the France now in a randomized situation. The last question is how to boost the immune response. And Nikolai knows this drug, the azoxystrobin bromide from Russia. We test in our INSERM unit the activity of this drug in vitro, showing that it enhances the T cell activity and also the maturation of dendritic cells, particularly from immature to mature, and through the MDA5 inflammasome. And it's used in patients in Russia and in other countries like Iran, Slovakia, and other countries. There is a cohort of 100 patients having COVID-19, and I collect the data for 52 patients with a clinical benefit. I don't show you the results because it's an article in preparation, and I am the PI of a clinical trial, a randomized phase 3 study using this drug in COVID-19 And now there are 62 patients included in this week. Next one. Other question, as I mentioned to you earlier, is a dynamic immune follow-up. The immune susceptibility to COVID-19 infection, the high-risk period, and the example is autoimmune with a registry recently in the Lancet. Is of the hospitalized infection in these patients, either an HLA susceptibility, and we have to identify the immune suppression period and the immune exhaustion. Next one. There is also a question about the persistence of the virus. Is it linked to the immune exhaustion? There are some clinical symptoms which are present, and I saw some patients having that. The persistence of the virus from 1 month to more than three months. And some other patients are diarrhea, libido, muscular, articular pain, which is close to EBV uncontrolled, fatigue syndrome, etc. We have to analyze these patients and follow up with some particular aspects, I mean biological, including biomarker of immune exhaustion, which are known, NKG2T, PD-1, RAJ, IDO, and the metabolic change of the cells is also interesting. And for therapeutic purposes, immune adjuvant, vaccine, immune anti-PD-1, etc., could be interesting, but we have to deal with that. And cellular therapy with some programs with NK cells, and we are actually trying to start a program with NK cells, but it's just at a preclinical study level. Excuse me. The last, I think it's the last next one. The last slides in conclusion. In COVID-19, the most important is to be dynamic and to analyze the balance between the yin and the yang. This is precision immune medicine, the right patient at the right time with the right therapy. A careful follow-up, immune balance, and the aim is to limit the excess and to enhance the defects. I would like to thank you for your attention.
Thank you, Jean-Francois, for your wonderful presentation. And next we have Dr. Quinn, who will catch us up on COVID-19 in the UK. Barry, are you there?
Yeah, thank you, Albert. Can you hear me?
Yep. Yes.
Yeah,
yeah.
So hopefully I can control. If not, I'll ask the technician. So yeah, and the presenter. So thank you for asking me to share some of our thoughts. Now I looked at the timetable and I thought I would like move away from the scientific to more the human aspect of COVID-19 in the hematology and oncology setting. So I'm based at Queen's University in Belfast. And I was going to say a little bit about the situation here in the UK and in Ireland, and talk about what I've described as difficult conversations with those we care for. Now, I've tried, hold on, let's see. Oh, here we are. Is that it? No, technician, do you mind? What's happening now? Oh, it's, could somebody move it to the next slide? Because it's not working. Owner and good. So thank you. If you wouldn't mind taking control. So I just wanted to talk. You know well from the news across the world that the UK has been badly hit by COVID-19, and I think there's a lot of lessons to be learned now and in the future. I think the latest figures for the UK was about 280,000 people who had presented with COVID-19. Most of them were asymptomatic, mild to moderate, but it has resulted to date in about 38,500 deaths. And of course, some of those are people who have been treated for hematological malignancies and other forms of malignancies. So I just wanted to talk a little bit about those difficult conversations we're having with the people we care for in the light of COVID-19. Next slide. This, I just wanted to say that we didn't start off, none of us did, with a neutral playing field. We already had our opportunities and our challenges. So, we know about the advances in cancer treatment and care across the world up until now. We have seen an increase in people who are older or people living with comorbidities being able to get access to hematology and cancer treatment, but that brings its own challenges. Certainly in the UK and Ireland, we do have an ongoing discussion, argument, trying to prove resource allocation, whether that's drugs, equipment, and personnel. We have a shortage of doctors and nurses. This is all before COVID-19 came along. And then obviously we have the opportunity to use more technology to treat cancers, but also to support people living with cancer. And then along came COVID-19 and put even more challenge on the system. Next slide, please. So this, the WHO talked about, when you come across a pandemic such as COVID-19, it really shows you just how much resilience is in the system. And I would say in the UK and Ireland, we did not have a lot of resilience left. And you probably know that from, and I'm sure it's not that different maybe to the States and other parts of the world, France, Greece, and Turkey and other places. So I think that was one of our challenges, and we're seeing that, and maybe this is coming out in some of the things you see on the news and some of our figures. And then this I thought was quite good in the light of COVID-19. Billy and West talk about this sense of, as human beings, there's a desire to belong, and that sense of belonging is greater during a crisis such as COVID-19. And of course, this links me into the whole notion of social distancing, and in the light of protective measures that we already had put in place for people treated with cancer. Next slide, please. Here are some of the challenges that we are facing in the UK and Ireland. They're no different to your own countries, but here we are seeing delays in diagnosis because there's such pressure on the system. Resource limitations. So we have already problems with staffing with doctors and nurses, but then we have had doctors and nurses go off with COVID-19, or maybe they're shielding themselves, or we certainly have had some colleagues die of COVID-19. But the resources were already stretched. Bed allocation is a real issue for us, as it is across the world. So who gets the intensive care beds? Who gets the high dependency beds? And of course, this has an impact on some of the treatments that we as a multi-professional team have to make decisions about. It's the balancing the risk factors with treating the disease, but also the disease, but also the side effects and toxicities of treatment. This leads to difficult decisions for us as a team. These are all things that you have faced every day since this started. But I think really what's important is those difficult conversations which we've had with people who have either been newly diagnosed with a malignancy, or maybe somebody who is expecting their next program of treatment, or people who know that their disease is advancing and it is unsafe or it's impossible for us to move to the next stage. And therefore, they are in a state of limbo. And it is not uncommon for people that I have supported and cared for to talk about feeling abandoned by the hematology and the cancer team in the light of COVID-19. So we can talk about that if you want. Next slide, please. So this is a nice reflection. You may have something similar, but Michael Rosen, who actually is a poet laureate, a children's poet laureate, and he wrote this poem, but he himself spent quite a bit of time in intensive care. And he talks about the role of the doctors and the nurses in healthcare, not just during COVID-19, as the hands. And he uses this poem, this is just a bit of a, but he said, these are the hands, i.e. the doctors and nurses, that touch us first, i.e. at birth, at birth. Feel your head, find your pulse, make your bed. And then he goes on to say, these are the hands that touch us last. It's just a nice reflection on the human aspect of what we do and what lies behind some of the studies that my last two colleagues have spoken about. Next slide, please. So what I thought I'd just do very briefly, I'm conscious of time, but just mention 3 case studies that myself and my colleagues have dealt with. And again, this is no different to across the world. But this is the first case where this case study was Raj. He was a 34-year-old man who was diagnosed with acute myeloid leukemia in March, and he obviously was a candidate to proceed with his treatment in line with the UK guidance, but also international guidance. He was aware that he was commenced on treatment, and he knew himself he would spend long periods of time in hospital, which is not unusual. But the backdrop to this was, he was a young man who was told about the risk of infection, and he had been obviously very much aware from his family, but also from the media, which doesn't always present things accurately about the fear of COVID-19. So that was what he was trying to deal with. He did continue to try and use social media for family contact, but in fact, his closest family contact was a friend. And I'll come back to that in a moment. But one of the things he talked about, this is one of the people who talked about feeling abandoned by the team, was this even greater sense of isolation. He noticed that staff were spending less time in the room, and that was to try and protect him. But he also talked about protective equipment getting in the way between him and the people who cared for him. And this was also something that our nurses and doctors have spoken about. He described it as a very challenging and a frightening time in the light of this new diagnosis. And he talked about the lack of support due to social distancing. Very simple thing we did was that before every shift, the hematologist, the oncologist, or the nurse would say hello to Raj before donning the protective equipment. And the other thing we did bend the rules to allow his friend to come and spend some time with him. So again, this may be not unusual, but I want to come back to this sense of leadership and some of the lessons that we need to learn, certainly in the UK and Ireland. Next slide, please. So this is a case study of Morning, who is a 64-year-old lady who lives alone, but her closest friends, family, is her daughter and grandson. She was diagnosed with lung cancer back in December, and the decision was made to continue on with her treatment in the light of risk of infection and COVID-19. Maureen was isolating at home, and she was very frightened of COVID-19. Again, she was being told time and time again about protecting herself from infection and then the fear of COVID-19. Although she was part of a friendly neighbourhood who they were practicing social distancing, so Maureen felt very much alone. She had a strong religious faith, but was unable to attend her place of worship as it had been closed due to social distancing. So again, this was the human impact of somebody dealing with lung cancer with a poor prognosis. We like other speakers have said, we moved to telephone clinics from the oncologist and the nurses, but we also enabled her to do video streaming of worship so that she could get some comfort and support at this time. But these are just 2 examples of many across the world where people who are struggling to go through the treatment that you and I are involved in delivering or in supporting. And the third case study, the next slide, sorry. Okay, thank you. So this is a difficult one, and we've all been involved in this decision-making process. So Jack is 46. He lives with his wife. They only married last year. They married because they knew that his prognosis was very poor. He has advanced metastatic colorectal cancer. He knew already that his treatment was aimed at palliation. He had a prognosis of 6 months in December. He had a number of recurrent infections linked to an indwelling bile duct drain, and his treatment was postponed and eventually stopped due to COVID-19 risk. Now, Jack and his wife and we as a team had to face the reality that his disease would advance, but the risk of him undergoing any treatment at this time was not acceptable. And again, the backdrop to this is that in Jack's last few months of life, he is self-isolating with his wife at home, so some of the normal social interaction of going for a drink with his friends or going for a meal with his wife has been taken away from him. So these are just three of our case studies, which I'm sure you come across day in and day out. And some of the hidden impact of COVID-19. I think particularly any older person with a comorbidity who's going treatment for a malignancy at the moment, it is a very difficult and tough time for them. Next slide, please. So Michael West has done a lot of work here in the UK around leadership. And then he talks about leadership, and I mean us as doctors and nurses and managers is the most influential factor in shaping the culture of healthcare. The reason I say that is, while there have been wonderful examples of innovation here in the UK and Ireland, where there have been wonderful examples of care and clinical decision making in the UK and Ireland, I would say leadership in health and social care in the UK and Ireland could have been much better and should have been much better. And I don't know that if you can see that in states, Greece, Turkey, France, but I think there is lessons to be learned of. Where is the clinical leadership? Where is the voice of doctors and nurses during this COVID-19, particularly around cancer care? Next slide, please. So this is just talking about the need for compassion alongside our clinical skills. And just Churchanov in 2007 said, what compassion is awareness of the suffering of another, coupled with the wish to relieve it. And we do that, treating the disease, but also supporting the patient. And Eric Castle, a physician, wrote back in 1991 that we still need to engage with the suffering of those who are ill, and yet sometimes as doctors and nurses we might avoid this task. I do believe that there's a lot of suffering going on at the moment in the backdrop to COVID-19, and it's just I think it's something that we're aware of and we try to do our best with. Next slide, please. These are just some of the skills I think we as doctors and nurses need, and certainly in the UK and Ireland, I've been sharing this with other colleagues, but it's that thing to listen and to learn from and to hear the concerns of those we are caring for, having the courage to talk honestly to the people we care for about the decisions we're making, but also to have the courage to talk to the power brokers and the people holding the resources, not only now, but moving forward. The need to be honest with ourselves and with those we support. Creative solutions like, for example, some of the things that we've heard about, using more and more technology, social media to support patients, that need to be present with people when they feel we may be abandoning them because we are postponing treatment, and continuing to serve from a place of compassion. Next slide, please. Alistair Campbell talks about the role of doctors and nurses at any time in health and social care is to use our clinical expertise, our clinical knowledge, our clinical skills. But he also argues that alongside that is that continuing need to be a companion, to be a support, to be a friend to those we care for, to share our humanity. And again, I think this goes a long way to remove that sense of feeling abandoned, and which I think is part of living with cancer, that sense of feeling alone, but made worse by the COVID-19 situation. And finally, next slide, I think this is I just think Henry Nguyen is an American, comes from a spiritual background, and he says, he's talking about us as doctors and nurses and other healthcare workers, as busy, active and relevant practitioners. We want to earn our bread, our money, or by making a real contribution. And that's why we came into this profession, to make a contribution, to make a difference. This means first and foremost doing something to show that what we do, our presence makes a difference. But he says sometimes we ignore our greatest gift, which is our ability to enter into solidarity with those who suffer. So that is all I have to say. I just thought I might take a little different track by focusing on some of the human aspects behind them, which we're all dedicated to doing in the world of cancer, but against the backdrop of COVID-19. So thank you. Thanks, Albert.
Thank you, Barry. And also thank you for reminding us of the human cost of the pandemic and what we all can do to mitigate that. Next, we have Dr. Maiolino from Brazil, who will tell us about COVID-19 and hematology.
Thank you. First of all, I would like to thank to Onur, to Dr. Beppe Salio for this kindly invitation. My talk is about facing COVID-19 in hematology. It's a report data from an hematology and transplant unit in Brazil. Next slide, please. I can do it. Yeah. Here we go. So Brazil is in the center of the pandemic. Maybe we have the worst situation nowadays in all around the world. We have now unfortunately, more than 30,000 deaths in Brazil and more than 300,000 new cases of COVID-19 in Brazil. So nowadays, Brazil is in the center of the pandemic, unfortunately. I would like to present the data from the Complexo Hospitalar de Niterói. This is a large private facility which we have an hematology and transplant unit who receives patients for stem cell transplant and hematologic patients for chemotherapy and immunotherapy. The stem cell programs start since 2007. We perform a median of 100 autologous and 30 allogenic stem cell transplants per year, related, unrelated, and haploidentical. We have a 26 HEPA-5 single-room beds, a day clinic hospital with 15 beds, and we performed also a solid organ transplant program, kidney, heart, and liver. This is the number of transplants that we have. In blue, we have the autologous, and orange, the related allogenic, and the yellow, the unrelated. So you can see here, in 2020, we have less transplants. And here you can see that the case timeline of COVID-19 in our unit. The first case reported was in the second week of April. In blue, you can see the community transmitted cases, and in red, you can see the intra-hospital cases. So we have 11 patients diagnosed in our unit with COVID. This is the characteristics of these hematologic patients. 11 patients in total. The median age 41 years, and we have also a pediatric patients only 3 years old. But fortunately, this patient has a very, very mild COVID-19 infections. The majority was male. We have 3 acute myeloid leukemia, 3 lymphoid leukemia, 1 myelodysplasia or multiple myeloma, and 1 Hodgkin disease. And we have also 2 patients at the haploidentical allogenic stem cell transplantation where we diagnosis a COVID infection. Concerning the symptoms, the large majority of patients has fever, followed by cough, dyspnea, asthenia. We diagnosis mild cases in 2 patients, moderate cases in 5 patients, and severe and very severe COVID-19 in 4 hematologic transplantation patients. Concerning the comorbidities, we have 3 patients over age 60. We have 27% of patients. Cardiological disease, 2 patients. Diabetes, 3. Chronic renal failure in 1. And obesity in 1 patient. And more than 2 comorbidities, we have diagnosed in 4 patients. Concerning the lung CT scan, you have limited ground glass opacity in 2 patients, and more than 50% in 4 patients, and diffuse ground glass opacity in 3 patients. This is the laboratory findings. Interesting, we have 5 patients with neutropenia, which comprise 45% of our casuistic, and we have many complaints of inflammatory markers as protein C-reactive protein, the dimer level, and ferritin, very high. Here, the outcome. Fortunately, we have 5 patients recovered, 3 patients is still ongoing, and unfortunately, 3 patients dead. So I think this is very interesting and really a little bit surprising. We have performed a survey of healthcare workers, only for healthcare workers working on our unit, only on the transplantation and hematology unit. And as you can see, we have many cases. The first was diagnosis in 23 March. We have a cluster here in 9 April, and we have many patients in 19 April and also until 9 May. So we have a cumulative COVID incidence in healthcare workers and professional categories. We have physicians, related nurses, and others, professionals, healthcare workers, professionals infected. We screening 52% of the healthcare workers and 21% of patients. And we have symptomatic healthcare workers, we can diagnose COVID in 70% and only in 33% of the patients. What's the actual situation? We're still going on. The hematology unit and the stem cell program is still going on. We have 49 admissions to continue the treatment and the new treatment. The autologous program decreased in 50%. We have performed only eight patients, and the allogenic is still the same. 4 patients transplanted last month. This is our curve since January 19. As you can see here, a decrease in the autologous program, but from March to April, and have not a decrease in the allo transplant program. This is to show a particular situation of 2 patients. This is an ALL patients treated with hyper-CVAD, the first cycle. This patient was diagnosed in the 20th day of the chemotherapy. We stopped the chemotherapy, discharged the patient, perform again another PCR, and he started the therapy at the 2nd cycle. And these patients with non-Hodgkin lymphoma, we diagnosed the COVID-19 just before the start of the therapy. We stopped to initiate the therapy, wait for 7 days, wait for here from more 7 days, he's still PCR positive, and then he's here in the 21 days, and we start the therapy as soon as possible. So the Brazilian group, we have we perform 2 task force here in Brazil, one concerning how to manage lymphoid malignancy during the COVID outbreak, and another one was I was the leader managing patients with multiple myeloma during the COVID-19 pandemic. Both recommendations from an expert panel from our hematology society. This is the paper from how to manage lymphoid malignancies. Our group chose to divide the recommendations among the many types of lymphoid malignancy. You have, and we recommend a specific acting for each situation, for each disease. And for the monoclonal gammopathies, you have almost the same recommendation as in Europe. And really, multiple myeloma patients are elderly and have many comorbidities. They are really immunosuppressed. We have still few data on cancer patients, but multiple myeloma is a risk factor for severe COVID-19. We have organized our healthcare system. We implemented the telemedicine and the visits schedules. We are very concerned to the impact in the healthcare workers. This is a main issue here in Brazil. We modify a little bit the time to start the treatment, oral therapy preferred than endovenous or subcutaneous therapy. We delay the autologous stem cell program, prolong the induction of period of induction from 4 to 6 cycles, reduce the corticosteroid dosing, and treat only patients with clinical relapse. And the supportive measures is very important. The prophylaxis, antimicrobial prophylaxis, the bisphosphonates each 3 months. Vaccine for other pathogens, very, very, very important. And then the supportive care and the thrombosis risk in multiple myeloma is higher. And we follow the recommendations of the European Group for Thrombosis Prophylaxis. So we have many open questions. The COVID-19 pandemic is spread in Brazil. We have a very, very bad situation nowadays. But the hematologic treatment should be continuous. This is an incredible challenge for us. We need to have a very, the healthcare workers are in special risks. You are concerning about that. We have physicians, nurses with COVID-19 infections. The centers reports from Italy and Spain should be considered. We are considering to organize the Brazilian centers. And this is our new normal. And it is the time to reorganize and keep going. This is for me, is the main important message. Finally, I would like to thank my wife, Dr. Márcia Garnica. She's the head of the infectious disease at Hospital de Clínicas Niterói, and she collects all this data and take care of the transplant and hematologic patients. Thank you.
Nice.
Thank you, Dr. Maialina.
Thank you.
For the last talk, Vera Donnenberg and I will do our usual tag team double lecture, and we'll be talking about anti-inflammatory therapy as an adjunct to treatment for COVID pneumonia.
And we'll try to speed it up.
And we'll try and speed it up, yeah.
Can we control the slides?
I have the control right here, and it is not particularly working for me.
This one.
Yes, it is. Okay. So an outline, we're going to talk about IL-6, which we've heard a lot about today from Dr. Rossi and Dr. Sevgi and Dr. Hanan. As a driver of acute respiratory distress syndrome, we're going to talk about new findings treating COVID-19 pneumonia with an IL-6 receptor antagonist. In Pittsburgh, we have a vaccine candidate, and we'll give a little bit of advertisement to that. And for us cellular therapists, we'll also talk about using mesenchymal stromal cells to treat COVID-19 pneumonia. And then finally, we will describe a global adaptive clinical trial platform that's being used around the world to treat COVID-19.
Well, you actually heard a lot about this, especially from Rossi, that targeting hyperinflammation is critical. There are several groups of agents, anything from targeting the GM-CSF, JAK-STAT, TNF-alpha, IL-17, IL-23, IL-1, and a whole other group of cytokines, and of course IL-6 and IL-6 receptor. I think the reason why we're so focused on IL-6 and IL-6 receptor alpha is what Jean-Francois already mentioned. And that is not just it's a key cytokine, but it has two modes of action.
So the cascade is begun when the virus infects macrophages, as you can see at the top of this illustration, and dendritic cells and monocytes, eliciting a response that is both immunosuppressive with IL-10 and also hyperinflammatory with IL-6 and TNF-alpha. And as we heard briefly, IL-6 is a very interesting cytokine because it has a very, very specific target cell population, namely hematopoietic cells, which express both of the necessary components of the IL-6 receptor but once cells start secreting soluble IL-6 receptor alpha, then cells that only express GP130 can then respond. And these cells include endothelial cells and other cells that are not usually targets of IL-6. So that's why not just antibodies against IL-6, but also antibodies against the IL-6 receptor are very important.
Critical. Yeah.
Yeah, this reminds us that the IL-6 story didn't just start with COVID-19. It started in 2003 with the SARS-1 epidemic, and these three papers just indicate how the virus infecting macrophages actually elicits IL-6 and polarizes macrophages to be hyperinflammatory.
And TNF-alpha too. This is one of the first publications which came out of China, showing that infected CD14 blood monocytes on the left are shown in patients in ICU, in the blue shown in COVID-19 positive patients, non-ICU and healthy controls, that if you look at the bottom histograms, you can see significant upregulation of IL-6 secretion in monocytes and also in T cells. Further, CD4 positive T cells are shown on the top also secrete significant levels of GM-CSF, again indicating that perhaps both pathways and TNF-alpha pathway should be considered for therapeutic targeting. Again, as all the speakers before us indicated, IL-6 is the upstream cytokine for CRS, rheumatoid arthritis, and of course, CAR T cell administration. And I would imagine everyone on this webinar has significant experience in administering this.
Importantly, though, in CAR Ts, where the cells are being administered, precisely because they are effector cells and for their effector cell functions, administration of tocilizumab neutralizing the IL-6 receptor did not appear to interfere with CAR T cell efficacy. And of course, we want to be very careful when we're treating viral infections. We don't want to give something that prevents the effector response against the virus.
But again, there's the difference between acute administration, short-term acute administration, and long-term administration, such as in people with RA. So this is again one of the first studies which came out of China, was published first week of March in an online journal, and then republished in PNAS.
Just recently.
Recently.
Right. So this was a single arm study, 21 ICU patients who received tocilizumab single dose in addition to their standard of care therapy. And their results were dramatic. All of their patients defervesced within a few days, and 15 of 21 patients had reduced oxygen intake. Lung lesion opacity by CT resolved in 19 patients. There were no obvious adverse reactions, and all patients were recovering well. They had some clinical data that went along with this. And as you can see, going from left to right, there was a dramatic decrease in CRP, a dramatic defervescence, decrease in oxygen consumption, and an increase in oxygen saturation.
But basically, the bottom line was that anti-IL-6 receptor therapy, because they use tocilizumab, is a very promising approach to treat the COVID-19 associated pneumonia.
So an additional single-arm trial, also in China, also in Wuhan, had great results, not quite as uniformly positive as the first trial. And what we did is we sorted their data by the maximum level of IL-6, because they measured IL-6 for the first week of therapy. And when you sort by the maximum level of IL-6 that these patients who are on therapy reach, what you can see is that the patients who had persistent increases in high levels of IL-6 despite tocilizumab treatment, those were the patients that did poorly. And what this suggests is that that targeting the IL-6 receptor alone may not be sufficient, and it might. And of course, we have agents to target IL-6 itself, and small molecules to target JAK-STAT pathway, which is downstream of
and I see Jean-Francois laughing or smiling, and it completely agrees with the data he was showing.
That's right.
At looking at the plasma IL-6 levels, nothing in bronchoalveolar lavage or lung-related.
So again,
this was a crazy article, which we reviewed for a group of plastic surgeons. But it was an interesting premise that could administration of mesenchymal stromal cells actually change inflammation and mostly, or perhaps post-COVID lung fibrosis.
Right. As we're aware, as hematologists, MSCs have been proposed for therapy for a variety of different things, including graft versus host disease. And one of the disappointments of MSC therapy is that when you give them intravenously, most of them that you can detect wind up in the lung. But in this case, that might be a good thing. This was an odd trial. It had 10 subjects. 3 were randomized to placebo. They didn't say what the placebo was. 7 got MSCs, but they had good results, which is shown in the little blue table. For the placebo, 2 were alive and 1 died, and for a single infusion of MSCs, 1 million per kilogram, all 7 lived. The yellow shows a chi-square that I did on this. And with this number of patients, even though it looks promising, the p-value is 0.1, not even close to significant. And this just points out the need for real clinical trials. If they had the same results with 40 subjects, equally distributed as they did between placebo and experimental treatment, and got the same results, the p-value would have been 0.001. But we're left just thinking, well, this might be a promising approach.
But especially for trials like this, as Dr. Hamed said, it's critical to have some autopsy results after, because in this case, it is very, very clear that administration of these cells directly affects the local lung environment.
And the same trial did some cytokine measurements, but on 3 patients in one group and 3 patients in the other group. And they're all moving pretty much in the right direction. But again, what can you say with 3 patients? We're still pretty positive about the use of MSCs, and it's based on work by our colleague, Dr. Mauricio Rojas, who has looked at use of MSCs in both murine model and in a sheep model for both sepsis and for lung injury by delivery of bacterial lipopolysaccharide through a bronchoalveolar lavage. And if you look at the graphs, what you can see, we're looking at lung wetness on the top, and we're looking at total cells in the bronchoalveolar lavage on the bottom at 24 and 48 hours after treatment with LPS. And what you can see is that 2 preparations of MSCs, low passage, that we made, and I'll talk about how we made them in a moment, were very effective in protecting the lungs.
And this is in mice, but we have done the same thing in sheep. Administering in sheep human-derived MSCs, basically from this procedure.
So for a different study where we were doing with plastic surgeons hand and forelimb transplants along with bone marrow to promote tolerance, we were preparing bone marrow from vertebral bodies. And you can see us chopping up the bone marrow, and then it gets ground and it gets tumbled and it gets filtered. And the result is hematopoietic cells that were administered to patients. But we had a byproduct of the ground up bones after they were tumbled. And we found that with a little bit of trypsin digestion, we could release a very large number of native mesenchymal stromal cells.
I don't know you can see the numbers, but one little trypsin digestion and the jars are about half a liter. We had 5 billion MSCs.
To start with. So we were able to prepare very, very low passage MSCs, which actually are functionally superior to commercial MSCs, which get as many as 10 passages to reach cell bank numbers. Also, we work with Dr. Peter Rubin, plastic surgeon, and we make MSC-like cells, adipose-derived stromal cells, both from whole fat and from lipoaspirate, and we use these cells therapeutically. Next.
I'm trying. Let me quickly summarize.
So MSCs work by a variety of mechanisms that are known. It's mostly hit and run because when you infuse MSCs, they are very difficult to find, especially allogeneic MSCs, shortly thereafter. But they affect macrophage polarization, increasing IL-10, decreasing IL-6 and TNF-alpha. That's what we want to do in COVID-19 infection. They affect neutrophils, and they also promote regeneration of endothelial cells.
And probably protect or actually keep the regeneration of alveoli. And that again goes with Dr. Hammed's talk. So Pittsburgh.
So this is a plug for the Pittsburgh vaccine, which is now in limited clinical trial and safety studies, and it's a collaboration between 2 close colleagues of ours, Andrea Gambato, who actually made the constructs for the vaccine, and Lou Falo, who is the chairman of dermatology, who has been pushing this very novel microneedle vaccine array, in which the vaccine protein is attached to these little carboxymethylcellulose tips, and that's impressed into the patient's skin, and the needles break off, and they're very, very tasty to dendritic cells. And so the proteins that are being used are the monomeric spike protein, but also a version of a trimeric spike protein that also has a toll-like receptor domain to make it tastier to skin dendritic cells. And the reason that Drs. Gambato and Falo were able to get on this so quickly and actually get it out, because this is not a pharmaceutical company. This is a homemade vaccine.
Their labs are next to us. So
right. They first started doing this in 2003 for the SARS-1 epidemic, and that fizzled, so the vaccine never went anywhere. and again got this all out and all dressed up with nowhere to go for the MERS epidemic. So when the SARS-CoV-2 epidemic hit, they were all ready to roll.
And they were very pleased because the paper was under review for over a year. And
all of a sudden it was hot property and in the international news. So the data that they were able to provide was in a mouse model, and they showed that both of these constructs, the monomer and the trimer with the TLR, were capable of eliciting antibody against the virus. And later they showed that it was capable of eliciting specifically neutralizing antibody.
So now we have actually this vaccine is in clinical trials both in the US, in Pittsburgh and in Italy.
So lastly, I'm going to tell you about a trial that I'm surprised we haven't heard about earlier. It's called REMAP COVID, and REMAP stands for Randomized Embedded Multifactorial Adaptive Platform Trial for COVID-19. And this was initiated way back in 2016 as REMAP CAP, and the CAP is community-acquired pneumonia, because my friends in critical care tell me that there really aren't good standardized ways to deal with community-acquired pneumonia. And this trial design is very well suited to test interventions in the COVID-19 pandemic because it can test several treatments at the same time in the same patient, for example, an antiviral and an immunomodulator. Ongoing analysis of results means that you can have adaptive modification of the study arms. So new patients in the study have a better chance of getting better treatments. Treatments are dropped if they're shown to be less effective, and new treatments are added. And the scope is international.
And that's actually critical for COVID, because some of the ideas we had and we put forth cannot be done in Pittsburgh. We're in Western Pennsylvania, and our cases are, thankfully for us, quite low. So having the international scope is critical to this endeavor. And I'm looking at the map, and unfortunately, I see Turkey is not part, Brazil is not part of this group. And I don't know how easily it is to add sites, but this is something, Albert is very, very closely involved with this group. It may be worthwhile to investigate how to become participants.
The World Health Organization is involved with this too. So the way that the study is structured, there's a primary CAP domain, in which treatments like macrolide therapy, alternate corticosteroid strategies are tested. Virus-specific domains for COVID-19, antiviral therapy. We heard about, and some of these have already been dropped from the trial, like lopinavir, ritonavir has been dropped, and the option to add other antiviral therapies. And then there's the immune modulation arm of this. None, and when we came into this, interferon beta-1 versus interleukin-1 receptor agonists were being tested. And I and two colleagues wrote the module for tocilizumab for this trial, and that is being performed at several sites, but not in Pittsburgh because we don't have sufficient patients.
And I believe the hydroxychloroquine arm was also dropped because it was shown not to be efficacious.
Right. So this is a beautiful, beautiful slide that really sums up the tempo of the infection and also the opportunities for therapeutic interventions.
And this again, builds on what we heard from Jean-Francois and everyone else, that there are three different phases to the infection, and we need to be thinking about the sequential therapies, targeting, perhaps doing different targeting and sequential targeting of the initial viral response, because the disease progresses despite the viral load actually going down. And again, as several of us pointed out, one of the most critical targeting steps is then the hyperinflammation phase, which causes the demise of our patients.
So we expect that antiviral agents, and convalescent plasma would be important early in the disease when reducing viral load is the goal. But once that cat is out of the bag and you have runaway hyperinflammation, then we're looking at anti-inflammatory therapies, such as are shown at the bottom.
And again, maybe you're looking more for combination therapies. And our last slide is
our conclusions. COVID-19 pneumonia results from an immunopathologic hyperinflammatory response to viral infection. We've heard about this over and over today, but just a few weeks ago, we didn't hear people talking about this. IL-6 is present at high levels in patients with viral acute respiratory distress syndrome, including pneumonia caused by SARS, MERS, influenza, respiratory syncytial virus, and of course, COVID-19. The IL-6 receptor antagonist tocilizumab, sarilizumab may be effective in treating established COVID-19 pneumonia by blocking IL-6 signaling, and MSCs are preferentially trapped in the lung when given intravenously, so they actually that actually turns out to be an asset when you're talking about treating acute respiratory distress syndrome, and they can modulate inflammatory lung damage. There are several vaccines. I think there are over 10 vaccines right now in development and in clinical testing, including the one that we described from the University of Pittsburgh. And properly designed and powered randomized trials are almost always required for conclusive evidence of efficacy.
And if you have a minute before we show you the bibliography, I would like to come back to the administration, systemic administration of the antibody drugs. I noticed that Jean-Francois was showing a slide looking at IL-6 in bronchoalveolar lavage. And the question is, would a drug which is administered IV even peripheralize into the alveoli, because it's a large protein?
Well, you've got a 1,000-fold increase of IL-6 in the alveoli compared to the plasma. Then what are we doing giving the drug into the plasma? If it partitions one way, it partitions the other way. They're both large molecules. So we've been thinking about aerosolizing these antibody drugs and giving them by that route of administration.
And bibliography. And this sort of echoes every presentation we heard today. International participation is critical to our survival. And for getting this together, we really want to thank Birol and Beppe for forcing us to get together. And of course, the man, Onur, who actually does it.
And our motto at work: think positive, test negative, and thank you, Barry, contribute.
And this is actually a picture. This was not staged. This is what it looks like now for us at work. And you know, we had to close down the research laboratory, and we have to reduce staff. But we're plugging along. So thank you.
So Birol, are you going to say something, or Beppe, to close this wonderful session?
Yes, I'm so happy, and thanks to you for this beautiful presentation. But I would say thanks to all the participants of this long webinar that we have today, to all the ambassadors that come together. They have been able just to give us, I would say, a complete presentation about the situation of the COVID-19 in the world. So it's been a very exciting Sunday, although it's Sunday. And we started from Brazil. We went around the world in a very exciting way. And so I think that, what can we say? That we hope to be soon out of this tragedy. I would say that in Italy today, I've seen now that at 6 p.m. you have always the report of how things are going on. And it's, since the last few days is going better and better. Now we have only a limited number of new positive cases, although we are performing a lot of swamps and so on. So I think that it's very important just to continue this way. And let me say that after several months, I've been personally extremely happy to have the possibility to see all of you again. And we hope to have really the possibility to have in October our meeting in Istanbul, and that all this period, terrible period, will end soon. Thank you very much for your participation and your attention to the activity of our group. Thank you.
Okay, thank you. Bye-bye.
Bye.
Bye-bye. See you again.
Thank you, everyone, for your
Thank you
contributions.
So much.
Thank you, everybody.
All in person.
Very nice experience. Thank you to all of you. Thank you very much.
Thank you, Becca.
Thank-
Bye.